Hi, good morning, everyone.
Good morning.
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 And there are a few students still showing absent. Giovanna, Samantha, Simon. Yeah, these three students. Anyone having issues scanning the QR code?
Yeah, I don't see any QR code.
Okay.
Professor Straw, were you able to check
Yes.
again?
Yeah, I checked you in, Killer, already.
Thank you so much.
Okay, so only one I am missing is Samantha. And someone drop a text for Samantha, please, in your group chat if she's having any issues.
Professor, she worked a knock shift, so she's logging in now.
I'm sorry, what was that, Kayla?
She got off late work, so she's logging on now.
Okay, thank you. Okay, let's start a lecture. Okay, any questions, guys, before we start the lecture?
Hi, Professor. Sorry, I'm on. I just got off work late.
All right. Did you scan the QR code?
I am right now.
All right. Okay. So good morning, everyone, once again, and let's move on with the last three chapters. Sorry for the background music. It's the because is it loud? Yeah. Oh wow, okay. It's my gardeners going on full speed. Okay, so the first chapter we're gonna go over is your dermatology. So discuss common dermatology conditions and common drugs used. Majority of them will be like topical products. And any interaction, contraindication, adverse effects, as well as important points, developing nursing care plan or educating your patient. So when we talk about dermatology, the first thing comes in mind is skin, putting stuff on skin. So what is skin? Skin is the largest organ of the body, so it covers the body, serves many functions, such as the basic, one is protection, sensation, temperature regulation. I forgot to ask you guys, can you see my full screen? Yeah. Okay.
Yes.
Okay. Thank you. Excretion, absorption. These are common functions uh, played by skin. So it's made up of two layers, the dermis and the epidermis. The outer The outer skin layer, your epidermis, is composed of 4 layers, such as stratum corneum, stratum lucidum, granulosum, and stratum germinatum. Under the dermis, there's a rich supply of blood vessels, the nerves, lymphatic tissue, elastic tissue, connective tissue, which provide extra support and nourishment to the skin. There are also endocrine, exocrine, endocrine glands, and the sebaceous glands, the hair follicles. This is another way to look at it. What are the functions of the skin? But it's the same thing what we talked about. The dermatology drugs, there are many different types based on different type of issues, concerns experienced as associated with the skin. It could be viral, fungal, bacterial, and that's how you select the medication based on whatever the cause is. So for example, bacterial skin disorders such as your folliculitis, impetigo, frunicles, carbuncles, cellulitis, and then you use antibacterial creams, ointments, or in some cases oral as well. And then for your fungal infection, use antifungals. And for viral infection, use antiviral. So let's go over some. For example, here, bacitracin. Bacitracin. So this is an antibiotic. Excuse me, antibiotic or antibacterial, whatever you call. So it prevents infection and minor skin injuries. If somebody has a cut on skin, has scrapes or burns, minor ones. So most commonly you'll see as an ointment, and it stops the growth of certain bacteria on the skin. You'll find it OTC alone, or you may find it as a combination product, as in Neosporin, which is combination of neomycin, polymyxin B, plus this bacitracin. As far as the mechanism of action, it inhibits the bacterial cell wall synthesis. And as far as any adverse effect, not only this, majority of these products which are topical, the adverse effects are minimal and they're localized wherever the site of application is. In that area, either minor redness, itchiness, rash, in some cases, those are the most common adverse effects can happen. Okay. This is also very common. Neo and poly, neosporin. This is combination of neomycin and polymyxin B, OTC product. Once again, it's an antibiotic. Okay. Now this is mupirocin. This is an important one. Okay, important one. So this is also an antibiotic for treating skin infection caused by bacteria, and one of the important one to know, that's for impetigo, IMPETIGO. Somebody ask you what it's used for. Skin infection commonly caused by staph and strep, Staphylococcus and Streptococcus impetigo. Okay, apply topically. Now, one more thing which is really important to know about mupirocin, Bactroban. There is an intranasal form for this drug, and the intranasal form of Bactroban is used to treat nasal colonization by MRSA, MRSA. Okay, so these are two different indications, and they're both important. Staph and strep impetigo, which is your skin infection, and the intranasal form of mupirocin, Bactroban, is used to treat nasal colonization of MRSA. Okay, everybody got that? Those are the only things which you need to know about this drug. Now, next slide is also equally important. That's also a very important drug. Silver sulfadiazine, or Silvadine. Silver sulfadiazine. Anybody has ever seen this cream? No? Okay. This is used in burn patients, okay? Important to know what it's used for. Burn patients. What it is? Antibacterial. It's an antibiotic cream. Okay, and the use is to prevent or treat, both. Prevent or treat. And what type of burns? Second and third degree burns. Okay, so please know that as well. Second and third degree. Because first degree, they are mild. Second degree burns, they're partial thickness burns. Affect the epidermis and the dermis, the lower layer of the skin, can cause kind of pain, redness, swelling, blistering. The third degree burns, they are called full thickness burns, go through the dermis and affect deeper tissues down there. So we know what it's used for, burn. Second and third degree, right? And can be used to prevent or treat infection related to second, third degree burns. Okay, now if we read the name again, silver, what does it say after that? Sulfadiazine, right? So sulfa, it tells you that it's a sulfa drug. Sulfa drug. And sulfa drug known to cause a lot of skin adverse effects. So we have to make sure if somebody is allergic to sulfa drugs, it shouldn't be applied to those patients. Right? Everybody clear? Any question? Okay. Okay. Today's chapters, they're very important, but they're simple. They're not complex. They're quite simple. Okay, so we're clear about this product. Now here comes a very common concern, acne, right? Very common issue. If you read the names, there's kind of a hint in their names, like why they're named like that. Black hats because their heads are black, they look black. White hats because their heads are white, right? Then papules, they are more reddish. They're red. The tops are red, and the pustules because it's filled with the pus. So that's why they are kind of white colored head there, and the surrounding is this. You'll see like a slight redness and the bump because there's inflammation. And then nodules, they're large. But when you press them, they're quite hard. On the other hand, the cyst, they're large, but they're softer. So now, blackheads, whiteheads, what these are? They're called comedonal acne. Um, whiteheads because they're closed ones. They're closed comedons where the pore is clogged with oil and dead skin cells, but remain closed at the surface and giving it that white appearance. Blackheads are open ones. They're open where the pore is partially clogged. The surface is now exposed to air, causing the clogged material to darken in color. That's why they look black. Okay. Now the other ones, the bottom ones, those are inflammatory ones, like your papules, pustules, nodules. They're all inflammatory. Okay. Okay. Now, anti-acne drugs. It's a common issue, especially young age, and they are more concerned about how they look in that age as well. So very common condition, and you should know about the common products used. You start with the mild and then you step up. Means that you start with OTC products, and majority of the time it's benzoyl peroxide. Benzoyl peroxide is kind of a starting point. What does it do is, it releases oxygen, and the bacteria doesn't like that. They can't survive in that atmosphere, so they die. So it reduces the bacteria and also has a mild drying effect, which helps removing the excess oil in dead skin cells. Okay. Then there are antibiotics, like your tetracycline, very common used. Then there's clindamycin, erythromycin. These are very common ones used. And most of the time topical, but you will see some of them orally as well. Then there are retinoids, topical retinoids. Example, your tretinoin, adapalene. They promote the cell turnover to prevent the clogged pores. They can be used for both non-inflammatory and inflammatory acne. Um, Then in some cases, you may see patients taking spironolactone, which is an anti-androgen, decreases the androgen level, reducing the sebum production, usually in women with hormonal acne. And also corticosteroid. Okay. And then more severe, some cases you will see light laser therapy and that kind of stuff, or microdermabrasion, that kind of stuff. But you'll be dealing here with more common stuff. This is another example, some names there like your adapalene, clindamycin, benzoyl peroxide. The brand name is Benzaclin, which has the benzoyl peroxide OTC product mixed with clindamycin, which is an antibiotic. It comes in like a powder form, and the pharmacy add water, mix it up before they give it to you. Then tretinoin, benzoyl peroxide itself, and then your hormonal pills. This is how they look like. This is your benzoyl peroxide OTC product. This is Benzaclin, combination of benzoyl peroxide and clindamycin. This is tretinoin. This is azelaic acid. This is adapalene. Okay. Now, benzoyl peroxide, OTC, commonly used. Only thing is we may need to educate the patient to kind of, keep the skin moisturized because it may cause dryness. There's another drug. Have you heard about isotretinoin? Yeah. Okay. Accutane, acetretinoin. It's used for severe acne. And there's something important you need to know. It's a high-risk drug. Okay? High-risk drug. So usually those patients, they're given a green card. Okay, green card. Not the immigration green card. It's a green card. It looks like, you may have seen the California medical insurance card. It's like white in color. It's similar. The only difference is that it's green in color. That's why we call it green card. And the same ID number, issue date, and all that. So they have to carry that card to the doctor's office, to the pharmacy. So every time they go, first basic thing is they need to go every month to get a prescription. You cannot add a refill on it. There's a reason behind it, that they need to perform pregnancy testing every month before they issue a new prescription. Okay, so pregnancy testing before the prescription. Then they will, at the doctor's office, they will add information onto a third-party website. It's called iPledge. iPledge. That whole thing, the website looks like yellowish in color. So iPledge. Two parts of that. One is the doctor office. They fill that. And then the second part is the pharmacy fill when the patient comes to drop the prescription or to pick the prescription at the pharmacy. They bring the card, and usually pharmacy has to go to iPledge. They enter the number, the authorization number issued by the doctor's office into iPledge system, and then it allows them to enter information. And then it issues another authorization number, which pharmacy has to plug in when they bill it to the insurance, and that's how it gets approved. Okay. Another point, it's related to that pregnancy, that they need to perform pregnancy testing, but also need to make sure that they use 2 forms of contraception while they're on this medication. Okay, the reason, it's teratogenic, pregnancy category X. Okay, everybody clear about that? Any question?
If a male is taking this medication, is it still the same? I mean, obviously they don't need to take a pregnancy test, but would they still need to come in every month to get, just the face-to-face with the doctor? Or
Yeah, they do that. The reason is it has many severe adverse effects, so they have to be closely monitored. Not only one issue, multiple things. There's always risk, and that is the reason, no matter who the patient is, they want to closely monitor. Sometimes they may have to run some labs, but it's real important for females, because it's not only about them, it's about the baby as well. Okay. Alrighty. Educate the patient how to use these products properly. Okay. Patients sometimes, they whatever they know, they are exposed to, they do things their own ways and end up wasting a lot of drug. It's like, getting that cream ointment on the palm and then they rub it here first and then they apply. That's just a wastage of pretty much, like I would say, like half of the drug they will lose on just the palm of the hand. They should have it on the tip here on the finger and then put like tiny dots, and with those tops itself, and then gently, gently spread it, not really massaging part, not that, just gentle. And then it's recommended these products they apply at night so that they have enough contact period. But before that, like washing with gentle soap, because these products could be kind of really tough on their skin. And then pat dry, apply it and let it dry, and then they might want to apply like a moisturizing cream or something, and then wash it in the morning. Okay. Now, let's talk about oral drugs. Okay. Doxycycline, minocycline, tetracycline. So technically the tetracycline class. These are the ones most commonly used. Now, let me ask you, if anybody remember in the antibiotic chapter when we were going over tetracycline, anybody remember what were the important points in the tetracycline class which are important for your patient? Either to avoid, prevent, or educate them about something.
Avoid the sun or wear sunscreen in direct sunlight.
Mm-hmm. Good job. What else? There's some real important points. Because one thing always remember, doesn't matter what the indication is, what you're using it for, the drug is going to have the same characteristics, never going to change. So those are really important. Anyone?
Was it the teeth discoloration?
Yeah, what was that?
And in children under 8?
Yeah, women pregnant or lactating and children under the age of 8 should not be taking it. And the reason is what just Jennifer said, permanent discoloration of tooth. Yes, guys remember it now? What else? Was there anything else?
The liver damage?
Okay. All right. Yeah, Tatiana, good job. Yes, no dairy product. The reason? Calcium as calcium. Okay, and calcium go and make an insoluble strong bond with tetracycline and flushes it out from the body without letting it produce any therapeutic effect, right? Making it ineffective. So no dairy product. Additionally, any other product which has either aluminum, calcium, magnesium, and very common example is your antacid. So should not be used along with them. It will make them ineffective. Okay. Everybody is with me? Yes, we're on the same page. Any question?
I kind of have a random question. I believe it's with doxycycline. Can't that be used as like an anti-malarial as well?
Yeah, it can be. Usually it's your hydroxychloroquine, but there are factors where you cannot use that and you may have to rely on alternate. All right. Here comes fungal infections and antifungals. Now, this is not a bacterial infection, this is fungal infection, and they can affect various parts of the body, skin, hair, nails, and under the nails, they're really tough, very stubborn, real challenging to treat. The treatment can go on for from months to years. Okay. Now, in the picture, what you see is what it's called. What it's called.
Is that like a ringworm?
Yeah, that's a ringworm because it looks like ring. That's why it's named ringworm infections. Now, there are a few terms I'm going to mention. I'll tell you what they are. Please make sure you know them. And they're named based on what part of the body the infection is. Number one. So they are tinea infections. They're called tinea, Tinea, tinea infections, okay? And the second word is wherever the infection is. For example, tinea pedis, infection there. What is pedis? Foot, yes. Good job, Daniel, yes. So tinea pedis, foot, very common name, athlete's foot, right? Causes itching, scaling, blister, usually between the toes. Number two, tinea cruris, Cruris. It's called joke itch. Where it is? In the groin area. In the groin area. Tinea cruris. Number three, tinea corporis, Corporis, corporis. This is when infection is in different parts of the body, not just localized in the groin area, everywhere else. Okay, it could be, you know, on feet or any other area. It's your corporis, all different parts of the body. Cruris is more than the groin area. Now, tinea, number four, tinea capitis. Cap. Where do we put the cap on? On the head. So this is the scalp. Infection of the scalp. Very common in children. They'll have like scaly patches, some hair loss, itching, capitis. And the fifth one is tinea unguium. UNGUIUM. Tinea UNGUIUM. This is the infection of the nails, causing them to become thick, discolored, crumbly. And this is a very stubborn one. Okay. Everybody got all five? Right. Then there's yeast infections called candidiasis, right? So usually the cutaneous ones, they affect the moist area of the body, like where the skin folds are, armpits, groin, under the breast. They are red, itchy rashes. And in some patients, you may see the pustules as well. And then the second type is intertrigo. This is also candidiasis, which occurs between the skin folds where the skin rubs together. And you may find an associated inflammation and infection as well in some cases. Okay. And then there's another one which is called pityriasis, Pityriasis versicolor, tinea versicolor, versatile colored. So color is lighter or darker from the surrounding skin in these infections. Okay. Now, as far as the treatment, you start with the least, and the least are the topical. So topical antifungal, usually they end with azole, like clotrimazole, miconazole. They are your azoles, antifungal. For your skin, nail infections. Then for more severe issues, then there are other prescription drugs such as terbinafine. They're for dermatophyte infections and like athlete's foot. Then there's cyclopyrox, which is used for fungal nail infection. And you may find oral drugs given for that as well, such as glycofulvin, itraconazole, terbinafine. It comes in PO as well. PO are not recommended antifungals, usually topical, but in some severe cases, the patient may need it. It's really important to educate the patient about the hygiene, preventative measures to give it to others. Always tell them to keep the areas clean and dry because moist areas are more prone. And they can use antifungal like powder in the moist areas, and tell them do not share your personal item like towels and clothing with others. And personal toiletries as well, keep them separate. Here are some common antifungal drugs, which we just talked about, like your azoles, like these are your azoles. Okay. Nothing different here, same as same, but let's go over some important ones here. This is an antiviral drug, acyclovir, brand name Zovirax. Important, okay? So know that drug. This can be used both for HSV1 and HSV2 infection. So please know that, okay? Acyclovir, Zovirax, can be used for both HSV1 and HSV2. Now, do you guys remember what are those HSV1 and HSV2 infections?
Oral herpes and genital herpes.
And how about two?
Genital
HSV1
herpes.
is oral, HSV2 is
Genital herpes.
genital herpes. So this drug can be used for both. Very effective. Now, second thing, remember, antiviral drugs does not cure. They reduce, shorten the sickness period. So you make sure you educate the patient that, hey, it's not going to treat right away, but it will definitely cut off the sickness period. Like, maybe the infection that lasted 10 days, but it may cut off to like 5 days, somewhere around there. Okay. The topical antiviral. And this one, you may have seen this, for oral lesions when kind of feel the cut here. And there are other drugs as well, but this is one of the most common one used. There's a pencyclovir, then there's a decosanol, which is your Abreva, right? Abreva. You guys heard about that? That's over the counter for cold sores, which are caused by HSV1, herpes simplex virus 1. Okay. So everybody clear about this drug? Acyclovir, drug of choice for HSV1, HSV2, and educating the patient that it's not going to cure your condition. It will cut off the duration of your sickness. Right. Now, next are your anesthetic, topical anesthetic drugs. Now, anesthetics are used to numb the skin, topical, right? Numb the skin. How? By inhibiting the conduction of the nerve impulses from the sensory nerves. So you're not letting the signal going to the brain, so brain can't sense it. Very commonly used with insect bites, sunburn, anything irritant causing those problematic symptoms where you need to numb the area. These drugs are used. Also, if you see under the ointment cream spray, it says EMLA. You guys know what that is? What that means? No, that's okay. It's called eutectic mixture of local anesthetic. So it's a combination product. It's a combination product, your lidocaine, prilocaine, and this is very commonly used. If you ever come across a patient with dialysis, those catheters, they are large. They're really big, okay, and they hurt. So they use this to apply this cream so that they can numb the area before they insert the catheter. Okay, that's a common use of that cream. They usually apply like or somebody's having just a localized, some minor procedure, they can do that as well, and they apply like somewhere from 30 minutes to an hour, before, and then it's ready and stay effective for about 30 minutes or so. Okay, these are your antipruritic drugs, means anti-itch drugs. Now, itching happens when somebody gets in contact with something irritant. It could be a plant, it could be a chemical, could be anything, or it could be just a bee sting, right? So your body release, yes, Kira. So your body release histamine. Now, Benadryl, diphenhydramine, it's an antihistamine, and when you apply it, it helps reducing that itching. But in severe cases, the patient may need a steroid, such as your triamcinolone, shown here, to suppress that response. Okay. Topical steroids. And once again, if you talk about adverse effect, pretty much locally, if there are any. Redness, itching, swelling, that kind of stuff. Another issue here is the head lice, okay, head or body lice. And these drugs are called ectoparasiticidal. Now, cidals are the ones who kills. Parasites, who kill the parasites. Which one? Ecto, who live on others. Okay, because they live on others. But lice can be transmitted from one person to another when they get in close contact with the infested individual, or their clothing, their crumbs, towel. Okay, so they, they lay their eggs and they kind of get attached to hair shafts. We call them nits, right? Could be on clothes, and pubic lice. It could be on pubic hair. So these drugs can help kill them, and then you still need to use that the special calm, the lice calm, so that you can kind of pull away all those nits, the eggs as well. And some patients may need a repeated treatment as well. And you also need to kind of wash their clothes and everything in hot water, or you kind of seal them in a closed bag or something for a few days, and then you wash it. So these are common ones. Your permethrin, your benzoyl peroxide is also used, but the other ones, your permethrin, malathion, ivermectin, spinosad, these are the more common ones and more effective ones. This benzoyl peroxide usually used in children under the age of 4 years. It's more safer for them. All right. For hair growth, okay, for hair growth. Rogaine is the brand name. Generic is minoxidil. It is a vasodilator, okay? It's a vasodilator. Dilate the vessel, increase the blood supply to stimulate the hair growth. Can be used in both men and women. Okay. Then there are oral drugs like your finasteride, Propecia. Okay, finasteride. Now that's a pregnancy category X, not in pregnant patients. Finasteride, Propecia should not be used in pregnant patients. Primarily, that drug, finasteride, it's used in older males with BPH, benign prostatic hyperplasia. That's what the primary use is. Okay. And then some herbal products such as aloe vera, if somebody had skin rash, itching and all that, sunburn, and that can also help soothe that area as well. Nursing implication part, okay. So talking about that important part of isotretinoin, amnestin, once again, used for severe acne, your nodular or cystic acne, not responding to other treatments. And use antibiotic, use topical products, didn't respond to that. So this isotretinoin, this drug belongs to a class retinoid. They're called derivatives of vitamin A. Now, what is important to know? Mechanism of action, decreasing the amount of the oil production, the sebum, produced by the sebaceous glands, and reducing the formation of acne lesions. It reduces the inflammation, reduces the redness, swelling around the acne, and also kills the acne causing bacteria. Okay, but important part here is the monthly pregnancy testing. New prescription every time, using 2 forms of contraception, not becoming pregnant while they're on this medication, and monitor their liver functions. So if somebody has a pre-existing liver condition, he should not be taking. Also, long-term use of this medication can increase cholesterol level. Okay, but more worrisome, more important aspect is the pregnancy testing, 2 forms of contraception, and monitoring liver functions. Any questions so far, guys? Everybody's doing okay? All right. Let's do some questions. Okay. Okay, good job. Yes, C is the correct choice. For that condition, it's a skin infection. Mupirocin Bactroban is the one which is used. All right, great job. Yes, C is the correct choice, guys. Using that medication, isotretinoin, patient should use at least 2 forms of contraception. Now that's a pregnancy category X. All right. Okay, nice. Yes, B is the correct choice. So burn patients, 2nd and 3rd degree burns, silver sulfadiazine, silvadine. Mm. All right, yes, acne vulgaris, B is the correct choice. Perfect, perfect.
Eczema.
Okay, great. Yes, A is the correct choice. Candidiasis. That is the meconical is used for candidiasis. That's a yeast infection. Okay. Okay, so once again, A is the correct choice. Bacitracin, it's an antibiotic and used for bacterial infection, not for viral, fungal, or parasitic infections. Okay, let's see if you remember that. Okay, guys, so the correct choice is A, tinea cruris. Yes, it's based on the location. Tinea pedis on the foot, tinea cruris in the groin, tinea corporis on the body, tinea capitis is on scalp.
I usually think of like cap, like you wear a cap on your head for the scalp,
Yep,
and then like corporate, like your body is a corpse.
yep, yep, good, 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 yes. All right, we are done with this chapter. You guys ready to take a break? No?
Yes, thank you.
All right, thought maybe everybody's doing like this. No, 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 we hit breaks. Right? All right, so let's take a 15-minute, okay?
Oh.
Alexis, I think your mic is on.
I'm not quite sure.
Welcome back, everyone. Let's turn the cameras on. Excuse me. All right, guys, let's start our second chapter of the day. Okay, ophthalmic drugs for the eyes. So we'll talk about the problems with the eye, the common ones, and the common drugs used, as well as anything important we need to look into, educate your patient, avoid anything your patient is on any of those medications. Yes, Carly. As I mentioned previously, I lost majority of my data, so I had to build up on it. So yes, everything is not highlighted. Okay, so just focus, like when whatever I'm telling you is important additionally to whatever is highlighted. So please add that. Okay. All right, now these three terms listed here, important for us to know what they are, and I'll give you a little tip. Let's first pick up the top two, mydriatics and miotics. Okay, now we're talking about the eye, and let's pinpoint on the pupil of the eye. The longer word, mydriatic. Okay, if you put both pal in front of each other, mydriatic and miotic. Mydriatic is the more lengthier one, right? So they dilate the pupil, make them bigger. Miotic is the smaller one, short one. It constrict the pupil. So any drug which are mydriatics, they will dilate the pupil. Drugs which are miotics, they will constrict the pupil. All right. And cycloplegics, they are used to temporarily paralyze the ciliary body. So, any procedure or, for example, somebody got any foreign object in the eye, they need to remove it. So temporarily they need to paralyze it so that it doesn't cause more trauma to the eye. These drugs are used. But mydriatics, miotics are the ones that either dilate or constrict the pupil. Mydriatics are used for like your dilated eye exam as well. So they relax the muscles in the iris. Mydriatics. Example, like if phenylephrine, on the other hand, miotics, they're like your pilocarpine, carbachol, then cycloplegics, such as your atropine, cyclopentolate. Let's talk about different conditions, different drugs. Anti-glaucoma for patients who are experiencing glaucoma or has a glaucoma, so to keep the intraocular pressure low. Right? And then antimicrobial, if somebody has a bacterial infection in the eye, anti-inflammatory for the patient who has some sort of inflammation in the eye, and aesthetics needed for temporary relief from discomfort, or maybe for a procedure, diagnostic drugs. These are, you can kind of, pick up the example like your dilated eye exams, anti-allergics, so for allergy symptoms, redness, watery eyes, and lubricants for the dry eyes. Basic point. Your patient might be using only one type of eye drop or multiple. Make sure if there is more than one eye drop, you space them out. Anybody knows how long that space should be? Five minutes. Okay, now we know it. 5 minutes. More than one, I drop, space them out by 5 minutes. The reason, if we are doing it too quickly, we're not allowing the drug to locally absorb. We're just washing it. So we need to give enough contact period for local absorption of the drug. Another thing, have you ever heard about putting a pressure inner canthus after instilling any eye drop? Yes.
It's to allow absorption.
What was that, Kayla?
Is it to allow absorption?
Allow absorption?
Yes.
Okay. Anyone else? Any different perspective?
Reduces the systemic absorption.
Yeah, brilliant. Yes. You don't want that drug to be systemically absorbed, because if the condition is localized, it's local, we want local effect, right? Now, let me give you an example. Do you guys remember beta blockers? The hypertension chapter, beta blockers ending in LOL, right? And do you remember patients with what condition we have to be cautious or not using that drug in respiratory condition? What was that?
Glaucoma.
What was that, Danielle?
Are you talking about glaucoma? Because then it would increase the
No,
intraocular pressure.
I'm talking about like which condition, which respiratory condition, is like contraindication, or it could be cautious. We should be cautious in those patients if we are giving them beta blockers.
Okay, sorry, asthma then.
COPD and asthma.
Asthma, COPD, right? Because it can cause bronchoconstriction, correct? Now, as I said earlier as well, drugs characteristics never change, no matter what you're using for. So if you're using a beta blocker, an example timolol as an eye drop, the risks still exist if the patient has asthma, COPD, correct? It's still a beta blocker. And when you apply pressure inner canthus, because inner canthus, this is inner canthus, okay? This is inner canthus. This is outer, this is inner canthus. And there are canals, canal which connects the eye to further down nose, throat. And the drug can be systemically absorbed. And it can be absorbed systemically absorbed, then it will have a systemic effect, even though less, but still. So in order to prevent that systemic absorption and systemic effect, we apply pressure for 1 full minute the inner canthus. Is that clear, guys? Yes? Okay. Let's talk about glaucoma. Big problem, okay? Big problem. Glaucoma is something risky, okay? Risky. The reason? It increases the pressure in the eye. You can say that hypertension of the eye, okay? What happens is that I'll show you in the next slide. The drainage canal is either completely or partially blocked. So eyes are not able to drain, and drain means it doesn't mean that outside, the drainage canals right in here inside. So they are blocked, and now in simple words, we call the water in the eye, or more specific terms, we call aqueous humor in the eye, that watery substance in the eye. It keep building up in the eye, behind the eye, right? In the eye. So that builds up more pressure. And that pressure negatively impact the optic nerve. Optic nerve is responsible for vision. So that can damage optic nerve and the patient can lose their vision. That is the reason it's important. And patients who are diabetic, over a period of time, they're at a high risk of developing this condition. So that's why we ask them, like, hey, go see your eye doctor at least once a year. Have them checked out. Now, there's a condition, this glaucoma happens in adults, and it can happen even in infants. They're born with it. Make sure you know that term. It's called congenital glaucoma. Okay. If they're born with it, infants, it's called congenital glaucoma. Now let's talk about glaucoma in general. This is an eye condition, can damage the optic nerve, which is crucial for vision. The reason? Abnormally high pressure in the eye, which is called IOP, intraocular pressure, right? If it's in here in the brain, it's called intracranial pressure, but in the eye, it's called intraocular pressure, right? Normal is between 12 to 22 mmHg, 12 to 22. So if it's higher than that, that's increased intraocular pressure. Some patients, glaucoma can occur even at a normal pressure. Let's open up glaucoma. Keep the congenital on side because we know that clearly that's when it's in infants, congenital glaucoma. Now, normal adults, it's either open angle or closed angle. Open angle and closed angle. Open angle is also called as primary, okay? And closed angle, sometime you may see it written as angle closure, but it's the same thing. Open angle, closed angle. All right, now what is the difference between them? And who's more severe? Who should we prioritize? Always remember, it's drainage which is clogged, the canal. And if it says closed angle, means it's closed. And if it's something closed which should be open to drain, but that's a big problem. So closed angle or angle closure is an emergency situation. The patient should be in the emergency department, and this happens suddenly. Okay, sudden onset, and the patient experience sharp pain, pressure in the eye, and they can rapidly lose their vision. So they should be in the hospital right away. On the other hand, open angle develops slowly. So the drainage is there, but it's not efficient, and slowly increase the intraocular pressure. Okay, everybody clear about these two different type of glaucomas, and we know which one is more dangerous, right? High risk. And then is your normal tension glaucoma, that the nerve damage occurs despite the normal intraocular pressure. And then there's secondary glaucoma, develops as a result of a different eye condition, something like they may got injured, there's inflammation, a tumor, or something else. Okay, but main focus here is like one separate thing, which is congenital, and then these two main ones, open angle and closed angle. Right. Any questions so far?
All right. Did you mention that you can use them like interchangeably, like the primary and secondary with open angle and closed angle?
Say that again.
Did you mention that you can use primary and secondary interchangeably with closed angled and open angled?
No. Primary is also called open angle. Okay. Angle closure sometimes also written as closed angle, but they are two different things. It's not interchangeably between primary or secondary or angle open or angle closed. Open angle, closed angle are two different conditions. Open angle sometimes called as primary, and closed angle you may see written as angle closure as well, but angle closure, closed angle are the same. Primary and open angle are the same. Okay. All right. Secondary is that it's happening because of something else. There's an underlying cause. All right. So somebody above 60 at a high risk patient have a history, family history of glaucoma, they'll be at high risk. Certain races such as African American, Hispanics are at high risk of open angle glaucoma. Patients with diabetes, high blood pressure, heart condition, they are high risk. Prolonged use of steroids that can increase the risk. And this is how it looks like. So normally, see, this is the drainage canal, and the fluid, the water, the aqueous humor can still come out and kind of, drain out. But here, it's partially clogged, and then it's not able to drain out here, and then the pressure building up that can damage the optic nerve. Another picture here, see open angle, that to some extent is still draining, not completely blocked, but on the other hand, the closed angle, it's completely clogged. And the open angle, it happens slowly, but in closed angle, it's a sudden. Symptoms are experienced sudden. Okay. And different type of drugs are used. For example, your beta blocker like timolol is a very common one used. Suppose a patient calls you, right? Or they came for a visit and they've been given a new prescription for timolol, and the patient saying, hey, like, Can I just stop it? Because like it's been many months, I'm feeling better. I don't have any issues since then. So I don't like the medications. Can they? What would be appropriate patient education? Other than staying quiet. Come on, guys, wake up. Come on, come on, come on. Taran, are you sleepy? No? All right. So that is a NO. No, 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 and no. And another no. And another no. All the no's, okay? It's a long-term commitment. They cannot stop that. They're pretty much stuck with it. If they stop it, intraocular pressure be high again. So even they're feeling better, still have to use it. So they must continue uninterrupted. Okay? Now the drugs which are used to reduce the intraocular pressure, they're direct acting cholinergic, indirect acting cholinergic, then they're adrenergic, antiadrenergic, carbonic anhydrase, inhibitor, osmotic, diuretic, prostaglandin agonist. Excuse me. Let's talk about them one by one. Cholinergic, remember, cholinergic, anticholinergic. Anticholinergic, like pick up an example like Benadryl, make you slow, sleepy, drowsy, dry. Cholinergic makes more secretions, wet, wet, wet. Okay, so cholinergic, they're also called as parasympathomimetic agents. They're used for glaucoma to reduce the intraocular pressure. How do they work? They stimulate the muscarinic receptors in the eye, leading to contraction of the ciliary muscle, which increase the outflow of the aqueous humor, the water in the eye, which lowers the intraocular pressure. Remember, two things are going to happen. The drugs, actually three things, okay, three ways it can happen. Some drugs will reduce the production of aqueous humor, the water in the eye, because remember, the water in the eye is not draining, and if it keep building up, the pressure in the eye, intraocular pressure, will increase, right? So either we decrease the production of aqueous humor, or we increase the outflow, push it out, then there is less, or there's some drugs like your Timolol, it does both, reduce the production as well as increase the outflow. So cholinergic drugs increase the outflow, leaving less back there, decreasing the intraocular pressure. Now, what are the examples? Pilocarpine, carbachol. These are common examples. So know the class, know how they work, and just know 2-3 examples under that. So for cholinergic, we know how it works. Stimulating muscarinic receptor, contraction of the ciliary muscle, simple words, increasing the outflow of the aqueous humor and decreasing the intraocular pressure. Example, pilocarpine and carbachol. This is how they look like. Carbachol, pilocarpine. And as far as like your side effects, they're more localized again, slight, I would say, itching, burning, redness of the eye in some cases, not that common though. Not have to worry much about it. Acetylcholine parcapin. Okay, now leave that. Okay, this is what the same we talked about, sympathomimetic. Nothing different in here. Okay, there are some examples here. You may have seen this alpha-GAN very commonly, opidine as well. So epinephrine, dipivefrin, these drugs increase, once again, increase the outflow, increase the outflow. Same concept, nothing, it's just other additional drugs in here, same mechanism of action, nothing different, nothing additionally you need to look into. Okay, here comes your beta blockers or beta adrenergic blockers, same thing. Beta adrenergic blockers, so here in this condition, used to manage your glaucoma to reduce the intraocular pressure and usually your open angle glaucoma, open angle. The next important question is, how does it work? Does it increase the outflow? Does it reduce the production, or does both? So it decreases the production as well as increase the outflow, resulting in lower intraocular pressure. Example, timolol. Timolol is one of the most common ones used, and then there are other ones as well. Timolol reduce the production, increase the outflow. Okay, these things are important to know. Okay, how do they work? And once again, going back to what we previously talked about, if patient is asking you, can I stop using it? No. And patient asthma COPD, you gotta be careful. Especially these kind of situations, you always recommend them putting a pressure here in acanthus. Okay. So the result will be decreased intraocular pressure for glaucoma patients, and they're used in open angle. Open angle very commonly long term. Okay. So adverse effect, once again, I'm not worried much about it, just the local effects. That's what I'm worried about, if there are any, not severe. Once again, timolol is one of the most common one used here, important one, and important to know the mechanism of action of this drug, decreasing the production of aqueous humor and increasing the outflow of the aqueous humor. And as I mentioned previously as well, and I'm going to say that again, this is a long-term commitment. They cannot stop it, cannot discontinue. And these patients most likely will have more than one eye drop. So if there's more than one, make sure you space them out by 5 minutes. Okay, any questions so far, guys? All right, if no question. Another important class, carbonic anhydrase inhibitors. Once again, the purpose is to decrease the intraocular pressure. Well, how do they work? Do they reduce the production, increase the outflow, or both? Carbonic anhydrase inhibitors, they reduce the production of aqueous humor, the fluid in the eye. And once you decrease the production, less there means lower the pressure in the eye, lower intraocular pressure. How do you identify them? They end with zolamide, dorzolamide, acetazolamide, brinzolamide. Here they are. They end with zolamide. We give it to patients with glaucoma who has increased intraocular pressure to reduce it. Okay. Adverse effects, same. I'm not worried about anything unusual. Same localized effects if they're burning, stinging, that kind of stuff, or maybe temporary blurry vision for a few minutes, which can happen with any. I'm not worried much about it. Now, osmotic diuretics. So diuretics causes diuresis, means more fluid going out. So osmotic diuretics are used for glaucoma to decrease the intraocular pressure by increasing the outflow. Mannitol is an important one here. So they increase the plasma osmolarity, which creates an osmotic gradient which draws water from the eye into the bloodstream, eventually reducing the volume of fluid in the eye. And that reduction in the fluid volume in the eye, the aqueous humor, causes a decrease in the intraocular pressure. So as I said, mannitol, usually given IV, is the most commonly osmotic diuretic for acute glaucoma, closed angle acute, because that was all of a sudden severe concern. You need to decrease the pressure right away, and because this mannitol acts within minutes, that's why it's used in acute conditions. Okay. And glycerin to some extent can help as well, but not that effective. Mannitol, as I said, for more acute conditions, can be used, might be used in some eye surgeries as well to reduce the pressure. As far as adverse effect associated, once again, I'm not worried much about it here. Now, the next class is real important, prostaglandin, analogs or agonists, prostaglandin. How do you identify them? They end with prost, latanoprost, travoprost, bimetoprost, defoprost. So all drugs, I will repeat this thing again, guys. Organize your things well, right? They will get mixed up otherwise. So, for example, when you are creating your study guide, right, write down at the top the drugs with one mechanism of action, for example, which decrease the production of aqueous humor, second one, which increase the outflow, and the third, which does both, like your Tylenol, right? Under that, write down the common drugs, make a mnemonic for that. That will help you to identify that, oh, this drug has this mechanism of action. And also write down these little tiny tools like what ends with what, how to identify prost. Well, that is a prostaglandin, and you identify that. On the top, you should have the mechanism of action. Because if we don't do that, we don't organize them, they will get mixed up. Prostaglandin analogs, they reduce the intraocular pressure by increasing the outflow. So we know the mechanism of action, increase the outflow. resulting in a lower intraocular pressure. We know how to identify, and then prost. Okay. Now, something real important to remember about. Okay, something unique. Your prostaglandin analog, which ends with prost. So if you find one of the drugs from this class, look for something in the question or answer options if they throw anything related to the color of the eye. Okay, the reason is the patients with colored eyes, it can permanently change the color of the eye. Okay, it changes the iris pigmentation, makes it brown. Patients with colored eyes. So if you skip this, you miss this, and the patient has colored eyes, and the problem is in one eye. Now the one eye is blue, the other is brown, right? And you're like, hey, look, like I gave you free color, right? And patient will yell at you. I'll be real upset. So make sure you're able to filter this. Also, this drug use long term, and in some patients, actually that's an indication it's sometimes used as well for eyelash growth. Okay, lining, thickening, darkening of the eyelashes, even though it's a side effect. And the patients who has a history of uveitis or herpetic keratitis, they should use this very carefully. So once again, guys, important. Patients with colored eyes, do not give them a free gift of brown colored eye. And that's permanent, okay? Permanent gift. Okay. Here comes your antimicrobial drugs. Antimicrobial means antibiotics, as well as viral, fungal infections, all those. Microbial means any microorganism. That is an umbrella term used for all these. So antibacterial for bacterial infection, antiviral for viral infection, antifungal for fungal infection. Now here, an example of your antibiotics, antibacterial. Your ciprofloxacin, moxifloxacin, these are fluoroquinolones, the broad spectrum. Then there are aminoglycosides, such as your tobramycin, gentamicin. Then macrolides, such as erythromycin, azithromycin. And then sulfonamides, such as sulfacetamide. And your polymyxin and bacitracin combination as well. So they are used for bacterial infections of the eye. But now, even though it's an eye condition, these drugs are used to instill in the eye, make sure that any adverse effect belonging to that class still applies. For example, your gentamicin. Gentamicin, it's an aminoglycoside. Tobramycin, it's an aminoglycoside. It can cause NO, nephrotoxicity, autotoxicity. So even though the dosage, I would say that very low to produce any sort of effect, but still keep an eye, especially for autotoxicity, if not nephro. Okay. Neopoly, you may see them individually, and you may see with a combination with corticosteroids. Somebody has an infection and that resulted in redness, slight, pain, swelling in the eye. Then dexamethasone, along with neopoly, which are antibacterial or antibiotic. So the steroid can suppress those symptoms quickly. And your ciprofloxacin is a fluoroquinolone, Moxie, same as well, ofloxacin, very commonly used. And you may see these drugs as eye drops, and you may also see the same drugs, otic drops as well for ear. Now, can you use interchangeably? Can you use vice versa? Eye to ear, ear to eye. It's the same drug. No. What is the reason? Why can't? Why can't you? Any idea, Taryn, would you mind sharing? No?
Does something going into the eye bypass the first pass effect, maybe? So no, it was just a
No,
guess.
it's something else.
Okay.
I think it would just be more irritating to the eye if you used an eardrop in an eye. I don't. Solution
So
wise.
what is different? Like why it will cause irritation? It's the same drug.
Well, I mean, maybe if it's depending on if it's ointment or drop related. I don't know.
Is it
It's
the
something else.
pH? A different pH?
Okay. The reason is eye drops and ear drops, two different type of formulations for different site of action. Eye drops are sterile products. Ear drops are not. So for eyes, you need sterile products. So sterile products can be used anywhere. So eye drops can be used as ear drops, but because ear drops are not sterile products and you cannot use non-sterile in the eye, so you cannot use ear drops in the eye. Does that make sense? Yes. All right. Perfecto. So that is the reason, guys. So you may come across, the pharmacy, they say, oh, you know what? Yeah, they gave you ear drops, but we're out. But we have ear drops. We have eye drops, I mean, yeah. So if they have eye drops and if they don't have the ear drops, can be used interchangeably, but not in the reverse manner. All right. This is your antifungal. For example, these conditions: blepharitis, conjunctivitis, keratitis. So blepharitis is a very common eye condition which makes your eyelids red, swollen, irritated, itchy, when they have the crusty dandruff-like flakes on your eyelashes. Be uncomfortable, but it's not contagious and doesn't cause any lasting damage to your eyes. The conjunctivitis is your pink eye, what we call pink eye, when the white portion of the eye becomes pink or a little reddish. And the keratitis is the inflammation of the cornea. which is the clear dome-shaped tissue front of your eye that covers the pupil and iris. Okay, so these are used for addressing those conditions. And this netamycin is one of those topical antifungal used to treat those conditions. And there are others as well, like amphotericin B, voriconazole for more severe issues. Then here, antiviral for viral eye infections, such as your trifluridine, ganciclovir, acyclovir, for different type of infection. Could be because of herpes simplex virus causing eye infection called herpetic keratitis. Then your valcyclovir, Valtrex, ganciclovir for herpes simplex virus, trifluridine for herpetic keratitis, once again caused due to herpes simplex virus. Okay, now trifluridine, adverse effect. Okay, adverse effect because of that, which is important for us to know. Trifluridine cause condition called uveitis. Uveitis. What is that? It is an inflammation of the eye. When the middle layer of the tissue in the eye wall, which is called uvea, is inflamed, and it's called uveitis. It usually comes suddenly and quickly become worse, like redness in the eye, pain, and sometimes blurry vision as well. Could be in one eye, both eyes, but it could be because of the adverse effect of that trifluridine. So please know what is uveitis. Okay, now anti-inflammatory drugs, ophthalmic anti-inflammatory to treat the inflammation of the eye. It could be because of simple allergies. It could be because of uveitis we just talked about in the previous slide. It could be because of conjunctivitis, or maybe post-surgical, because surgery is a trauma to the eye. And whenever there's a trauma, there's inflammation. Or the patient may have some sort of eye disease, can cause inflammation, and these anti-inflammatory ophthalmic drugs can reduce that inflammation. Very common. There are NSAIDs, such as your diclofenac, ketorolac, Stordal. These are NSAIDs, and very effective, usually given along with these, your corticosteroids, like a prednisolone, dexamethasone, those eye drops. They reduce inflammation. Remember, steroids' primary function, reducing the inflammation. Okay. Here are some examples of your corticosteroids. Okay. You don't have to worry about this part. Okay. Now here are your anesthetics. Local anesthetic, as far as related to eyes. Ophthalmic anesthetics. Well, where they can be used. For example, somebody is going for surgery. They need to just locally anesthetize it, numb that area for short procedure. Or somebody had a foreign object in the eye, they need to remove it. Well, they need to numb it. And these drugs ends with cane at the end. Cane, proparacaine, tetracaine. Drugs ending in cane are usually your anesthetics. Okay. Now, very common conditions, guys. Allergies. Allergies. So somebody's having symptoms of allergies in the eyes, watery eyes, itchy eyes, red eyes, allergic conjunctivitis. So they counteract the immune response in the eye triggered by any allergens, pollen, dust, pet dander, and the common drugs, such as your antihistamines. Antihistamines. How do they work? Antihistamine. They block the histamine receptors. Examples. Olopatadine, which is your Patanol and Pataday. Olopatadine, Azilastin, as here on your PowerPoint here. These are common ones. Then there are drugs called mast cell stabilizer. They prevent the release of histamine and other inflammatory mediators from the mast cells and eventually preventing the allergic symptoms from developing. Example, cromolyn sodium. And then there are some drugs which has a dual action, both as an antihistamine as well as mast cell stabilizer. And olopatadine is an example of that. And another one is ketotifen, Zadiator. Then they're decongestant for the eyes. Congestion of the eyes. It reduces the redness, swelling by constricting the blood vessels. Constricting. Such as nafozoline, tetrahydrozoline, which is your Visine, OTC eye drops. Those are your decongestant. But always remember to read the label and see what are the active ingredients, because they may have Visine written, but what's written after that can change what are the ingredients are, because same brand name, but it may have multiple ingredient addressing different symptoms there. Okay, and then comes your corticosteroids for short-term use only. Corticosteroids should always be short-term for inflammation, immune response. You need to suppress, and prednisolone is one of the common eye drops, your Pred 40, very common use. And your NSAIDs, like your ketorolac, brand name Acular, very common used. And in severe conditions, you may have immunosuppressants such as cyclosporin, brand name Restasis. It's used for extremely dry eyes. It comes in like a pack. There's a box and there's individually packed ampules, and you kind of, it's like a screw. You just open it and then squeeze it, whatever you used, and the rest you just toss it. Okay, so Visine, very common, guys. OTC products or allergies as well as other relevant symptoms. Then this is a newer drug, Excedra, and these are your artificial tears. These are ophthalmic lubricants called artificial tears to relieve symptoms of excessive dryness, irritation of the eyes. Okay. Always recommend the preservative-free ones, and single dose ones are better. They're gel drops, ointments, and can prevent or treat the symptoms of dry eye because there's insufficient tear production or poor tear quality. They're experiencing because of exposure to kind of wind, smoke, dust, different reasons, but it can cause extreme dryness, and these drugs can provide comfort to the eyes by providing moisturize to the eyes. This is restasis. See, these are the ampules looks like. You just kind of turn it one side and it just kind of tear from there, it gets separated, and you just squeeze it. Whatever you use, it's a single use, and you just toss the rest. It's a prescription medication, expensive as well. It's used for chronic dry eyes. Okay, for keratoconjunctivitis, it's called. Okay. Okay, nursing implications about that. Now, on this slide, only one thing at the bottom, how to use it. And in the picture as well, see, they are pulling down the bottom one, right? The lower conjunctival sac. So suppose it's an ointment. So you pull the lower conjunctival sac and then you apply a thin layer of that ointment and then tell them to close the eyes and try to kind of scroll the eye. Then it spreads around. Okay, lower conjunctival sac, remember that. And same thing for the eye drops as well. For eye drops, you just kind of instill the drops. You don't apply a thin layer, but in case of an ointment, then you just kind of apply a thin layer, the lower conjunctival sac. And then how to educate the patient to properly use these eye drops? You can tell them to look up, and once they do it, then pull the lower lid down. And if it's an eye drop, instill the number of eye drops. And if it's an ointment, then a thin layer, the lower conjunctival sac. And if it's an eye drop, once again, to prevent the systemic absorption, you educate the patient to apply pressure on inner canthus for 1 full minute. Is it clear to everyone? Any question? No? All right. Another point, guys. Ask the patient, do you wear contact lenses? Because if the drugs which can stain the contact lens, make sure you tell them to remove them. Okay. And all of these drugs, either it's an eye drop or more specifically the ointment, can cause blurry vision for a few minutes. So educate them not to drive for a few minutes. It's only about 10-15 minutes, but temporarily can cause blurry vision. Let's do some questions. Okay. We did not cover this, so let me go. Sympathomimetic drugs or mydriatics have the potential to react with other drugs as sufficient topical absorption occurs. When given concurrently with which ones can cause an issue, the correct answer is the C here, because with sufficient topical absorption, sympathomimetic mydriatics have the potential to react with them. The cardiac arrhythmia or cardiac dysrhythmia can get severe when they are mixed with either these thyroid hormones, because remember, somebody with hypothyroidism, they're kind of low, slow. And when they have too much of it, heart rate is high, they're anxious, and this can increase the impact and they may have cardiac dysrhythmia more faster. It can happen with cardiac glycoside as well, like digoxin, and TCAs, tricyclic antidepressant. But in this question, it's relevant to your thyroid hormones. Okay, next. Good job. Yes. So erythromycin eye ointment used or indicated for the treatment of neonatal conjunctivitis, which is caused by which one? Neisseria gonorrhea. Okay, good job. Okay. Okay, good job, guys. Yes. B is the correct choice. Meiosis. Open angle glaucoma. Because it causes constriction of the pupil, which increase the outflow of aqueous humor, decreasing the intraocular pressure. Okay, next question. Okay, great job. B, yes, because it's important to maintain the sterility of the eye drop container. It should not be rinsed with the tap water. Nice, perfect, yes. This is a sulfur drug, sulfacetamide, sulfur drug, and if the patient is allergic to sulfur drug, should not be given to the patient. Right. Okay. Okay, great job. Yes, guys. D is the correct one. Mydriatics, longer word, causes the pupil to dilate. And when the pupils are dilated, when they go out, direct sunlight, it hurts. So that is the reason you should tell them to wear the sunglasses until the pupil return to the normal size. That's what happens when they go for dilated dilated eye exam. Okay. Great job. Yes, guys, absolutely correct. B, Because it's an antihistamine. Antihistamine works by blocking the histamine receptor. Okay. Should be an easy peasy one. Okay. All right, everybody, C, C. Yes, yes, yes. C is the correct C. Congenital. Yes. Okay. Okay, looks like everybody is going with A. Okay, so let's talk about it. Patient prescribed epinephrine eye drops for treatment of chronic open-angle glaucoma. The patient complains of burning with installation of the drops. What statement is it? Nurse's best response. Based on your selection, it is a normal sensation because the eye drops reduce inflammation. Okay, normal sensation, maybe you're thinking that that's usually happen with eye drops, localized effect. But now if you read the rest half of the question, because the eye drops reduce inflammation, is there anything we read about that in order to reduce the inflammation or whenever there is a reduction of inflammation happening, then it has to burn? That's not a requirement, right? That's not related. So yes, it is normal, usual. So D is the correct choice here. Okay, it's a typical adverse effect, not concerning, and usually it will go away with few times of use. So D is the correct choice. It's not related to inflammation part. Is that clear? So read the whole question, all the options, and see which makes more sense. It could be normal, but nothing to do with that inflammation part, that in order to reduce the inflammation, that it is going to cause that. All right. So we're done with this chapter. Are you guys ready for another break? Yes. Okay, let's take another 15-minute, guys. Okay, and I'll see you soon in a few minutes. Okay, welcome back, guys. Let's turn on the cameras. Excuse me. All right. Last chapter of the day, guys. Otic drugs. Drugs used for ear conditions. So we'll talk about common issues related to ears, and then the medication used, as well as any contraindication, interaction, adverse effects, or important aspects when developing a nursing care plan or taking care of patients who are on any of these drugs. So before we start the solution, let's talk about the problem first. The ear, we need to know ear for hearing. So anytime if there is any ear condition going on, make sure you monitor patient's hearing. Okay. It can range from issues from mild to severe, and affect various parts of the ear. It could be outer, middle, inner ear, can impact the hearing. And if it's associated with middle ear, make sure that it can impact the balance as well, because middle ear is related to that. Okay. So outer ear disorders, it's called otitis externa, means outside. Externa, outside ear, outer ear. It's also called swimmer's ear. Infection or inflammation of the ear canal. Usually it could be a bacterial, it could be fungal infection, and the patient may experience like itching, pain, swelling, and in severe cases, maybe ear discharge as well. And another, a very common concern, earwax. Earwax built up. Cerumen impaction. So excessive earwax can block the ear canal, causing hearing loss or discomfort, and sometimes tinnitus as well. Okay, and patient may experience some sort of external ear trauma, may have like injury, cut, or blows to the ear that can cause swelling, bruising, hematoma. As far as middle ear disorder, the infection in the middle ear, it's called otitis media, middle ear infection. Infection with or without inflammation in the middle ear, usual, very commonly seen in children. Otitis media, very common in children. They experience pain, fever, hearing loss, and if the fluid accumulates in that condition, it's called otitis media with effusion, OME. There are many other conditions, but these are like more common. And then in the inner ear, condition called Meniere's disease, a chronic condition which affects the inner ear, causing episodes of vertigo, hearing loss, tinnitus, and feeling fullness in the ear. Okay, but majority of the time, you will be managing conditions with either external or the middle ear. That's the more common one. This is the anatomy of your ear, divided into three parts here: your outer ear, your middle ear, and your inner ear. So outer ear made up your pinna, which is called auricle, the visible part of the ear, which captures the sound waves and directs them into the ear canal. And then ear canal, which is your external auditory canal, a tube-like structure, which leads the sound waves from the pinna to the eardrum. And then the tympanic membrane, in a simple term called eardrum, a thin membrane which vibrates when the sound wave reaches it, and separating the outer ear from the middle ear. And as far as middle ear, it has ossicles, which are like 3 tiny bones, which amplifies the sound vibrations from the eardrum to the inner ear. They're your malleus, called hammer, then incus and stapes. Then comes your eustachian tube, which is a canal that connects the middle ear to the nasopharynx, helping to equalize pressure on both sides of the eardrum. And then finally, your inner ear, which consists of cochlea, a spiral-shaped, this one, fluid-filled organ, which is responsible for converting the sound vibrations into the electrical signals, which are then sent to the brain via the auditory nerve. And then semicircular canals, the 3 looped structures involved in maintaining the balance and spatial orientation, which is filled with fluid and lined with hair cells that respond to the movement. And then vestibule, which is a central part of the inner ear, which connects the semicircular canals, and the cochlea, which is involved in balance. And then there are auditory nerves, the cochlear nerves, which transmit auditory information from the cochlea to the brain. Now, disorders, as we talked about, from outside to middle to inner, otitis media is a real common middle ear infection, very commonly seen in children. Okay. Otitis media. And there's a acute otitis media and then otitis media with effusion when the fluid build up there. But acute otitis media, AOM, is the most common one, sudden infection in the middle ear caused by either bacteria or virus. And the patient may experience pain, fever, hearing problems. Usually kids, they can't even tell, like, they're scratching, pulling their hair, pulling their hairs, because they're having pain in their ear, fever, head is hurting. Most common, it's the ear infection. Very common in kids. Usually it's caused by your strep pneumonia, Haemophilus influenza, or Marksella catarrhalis. These are the most common ones. Then treatment, majority of the time, antibiotics. Amoxicillin, unless it's contraindicated, amoxicillin is usually the one prescribed to the patients. Along with that, because it can be quite painful, the patient may have fever, so analgesic and antipyretic can also be given. It could be acetaminophen or ibuprofen, or can be alternate. Okay. These are the drugs we're just talking about. It could be for bacterial infections, antibacterial. If it's fungal, antifungal. If they have inflammation, ear canal, anti-inflammatory. Certain conditions may require analgesic, anesthetics as well, and then corticosteroids to suppress the inflammation. And in case of cerumen buildup, earwax buildup, earwax emulsifier are used, such as your Dibrox, carbamide peroxide. Okay. Okay. Now antibiotics, all the drugs which can you use for any other infection can be utilized here, such as your ciprofloxacin, ofloxacin are common ones, and then cordyceporin, otic. You will see otic at the end, means that's for ears, because you may see the same drug given as an eye drop. So that is a combination of neopoly and hydrocortisone combination, because it has a steroid kind of helps better. Then tobramycin is also used commonly, gentamicin. As far as antifungals, so ends with azole, like your clotrimazole is common, miconazole, and there's a nystatin is also given for these conditions. This is common but important drug and condition, okay? Earwax emulsifier, over the counter, carbamide peroxide, generic, brand name Dibrox. Very important drug, okay? What does it do? It softens breaks down the earwax. Help to remove it. So carbamide peroxide, Dibrox, as you said, is the most common one. People use other things, but not that effective and not recommended. So one of the most active ingredient here is a common active ingredient is carbamide peroxide. It releases oxygen. When it comes in contact with the earwax, it releases oxygen, which helps break it down into smaller pieces and allowing it to drain more easily. Now, what else is important about this drug? How to use it instilled. First thing is, keep it at room temperature. Either this or any other ear drops do not use if they're cold. And do not warm them in the oven either, okay? So just roll it between your hands for a few seconds, and that should do it. And then in order to instill the drops correctly, you need to see who's your patient. Is it a kid or is it an adult? So divide it into two zones, okay? Below 3 and above 3. Below 3 years of age and more than that. So I'm going to show you a picture here. See, who is taller? Adults, okay? And not only adults, we are talking here about 3 and above. Anybody 3 and above, taller, so you're going to pull the ear up and back. In both scenarios, you're going to pull it backwards, but in one, you're going to pull up, the other, you're going to pull it down. So who's taller? You're going to pull up and back. In case of kids, for shorter, you're going to pull it down and back. So remember that, okay? Below 3, down and back. Above that, pull up and back. Everybody clear about that point? Yes? Okay. And then you can tell them to lay down sideways and, instill the number of drops, whatever needed, and just tell them to stay in that position for maybe 5 minutes so that the drug can be absorbed. This is a very important point. They ask questions on this all the time. Always have a baseline hearing so that you can compare if the symptoms are improved or not. Okay. And making sure, is there any condition which could be contraindication? If you have a perforated eardrum, certain drugs can't be used. And then assess, evaluate your patient's symptoms after the drug is given. See if the symptoms have improved or not. What would be a therapeutic outcome? Like, for example, earwax removal, may impact your patient's hearing. And then what would be an expected outcome after using this drug? Nothing is expected. Improved hearing. Okay, improved hearing. Okay. And as I mentioned earlier, keep them at the room temperature. If it has to be refrigerated, make sure that you pull it out from the fridge at least about an hour or so before you instill those eardrops, and always roll between your hand for a few seconds, about 30 seconds or so, because if you don't, if you instill too cold eardrops, it's called vestibular reaction, which includes like vomiting, dizziness. Okay. And what you just talked about, ages below 3 and above 3. So below, pulling low, below 3, pulling low and back, and above 3, you're pulling it up, up and back. Okay, let's do some questions. All right. Okay, looks like everybody like doo-doo-doo, which is the correct one. Because if you administer the eardrops too cold, can cause vestibular reaction, vomiting, dizziness. All right. All right, so once again, D is the correct choice, guys. That the outcome criterion for this patient is for the mother to demonstrate the appropriate administration of medication to the patient. Okay, good job. All right. So the purpose of steroid included in the zootic drops is to assist in decreasing the inflammation in the ear canal. as well as itching. All right, D is the correct choice, guys. Even though they wrote down ciprofloxacin along with DEXA, but they're asking about DEXA only here, steroid. Okay, next one. Okay, well done. Yes. D is the correct choice. When administering eardrops to adults, hold the pinna up and back. In children younger than 3 years of age, hold the pinna down and back. And then tell them to stay in that position, that affected ear up. If they are linked sideways, affected ear up. And if it's both ears, then make sure at least 5 minutes after installing the eardrops, they stay in the same position and then turn around using the other one. We need to give enough time for that drug absorption localized. Excuse me. Okay, looks like everybody's going with option B, which is correct one. Carbamide peroxide, Dibrox. Soften the earwax by releasing oxygen, breaking it down. Okay, well done. Perfect, yes. B is the correct choice. They'll use the eardrops and the ear canal to treat this condition. Okay. All right, yes, excellent. A carbamide peroxide is a commonly used OTC earwax emulsifier. All right. Right, great. Yes, B is the correct one. Improved hearing. Okay. Okay, for this, most likely choice would be A, because it's an otic condition and they have otitis media and otitis externa. So otic, but because of otitis media, they may need an oral bacterial antibiotic as well, not the antifungal. Okay. Oh. Well, we are done with the chapter. You guys realize that we are done with all the chapters today? Yeah. Wow. So pretty soon you realize that you're preparing for your final exam. Very soon. Almost there.
We still have to survive another test first.
Oh, you will.
A 10-chapter one.
Yeah, but remember, it's 10 chapters, but don't treat it as they said no exam this week, because that will be a problem. Oh, Eden, that's a good one. Make sure that you consider there is an exam and keep preparing the same way, because learning and remembering and doing well on the next test, all 10 chapters together in single week, is a huge mess. So please do not make that mistake. Okay, it's normal, the human mindset, like whenever we get a little loose, that then like, yeah, I got it, I have extra days, so let's just kind of relax a couple of days. That'd be the worst thing to do. Please don't do that. I am telling you now what's going to happen. It's so much material that I'll get mixed up. Everything will seem known and unknown at the same time, because we won't be able to connect them. So use this time. The total number of questions will stay the same. Only the final exam, I'll be 80 questions. Final exam will be 80 questions, and you'll have 80 minutes to complete them. Now, as far as our additional sessions, so we'll conduct that next week rather than this week, because then you'll have gap and you'll forget everything. So we want to keep it fresh. We'll see. If possible, then maybe we'll try to do that on the next Wednesday rather than on Thursday. If if that's an option, and we are able to, are you guys available next Wednesday as well in the evening?
Yeah, that's probably preferable. So then we can see our gaps in learning and then have more
Yeah.
time to do something about it.
That's what I'm thinking. At least you will have a day to kind of go through and think about it, practice rather than just kind of going for the exam the next day. So that'll give you a little bit room there. Okay, so I'm gonna try to schedule that on Wednesday. Well, I'll let you guys know that as soon as I do that. But I don't see any problem doing that. So I'll encourage everybody to, make appropriate accommodations, make yourself available, and attend the session. That will help you. And we'll do the same thing with your final exam. Final exam is on what day? What day is that? Is that Tuesday?
Can we get 10% back on the final?
Sorry, what is it?
Nothing, I was joking.
So, guys, so your final exam is on Tuesday. Okay. All right, so we'll try one thing, guys, okay? And I need your help in doing so. Remember, we have the presentations, right? So presentation, technically we have like, I think 3 days dedicated for them, right? So on 28th, 29th, and then 4th, correct? And on 5th, you have the exam. So if we can stick to the time frame really well, and we are able to conclude our presentations in 2 days, which is possible. I just had another cohort previously, I think just about a week and a half ago, and we're able to finish in 2 days. And then just before the final exam, because it's on Tuesday, maybe Monday, we can use those 4 hours, which is a good amount of time, 4 hours, and we can go slow and do that additional session, practicing questions and everything, calculations for the final exam on Monday. Sounds good? Because it will allow us more time. We can kind of open up things, discuss, ask questions. 4 hours, good amount of time, but 2 hours, we usually go 2.5 hours additional session. It's not less, but sometimes we feel rushed and we're not able to discuss everything there. And it will be fresh in your mind. Anything you need, you can ask and we can go over that. So that will hopefully give you an edge and help you to do well on the final exam as well. That's the plan. If we can wrap up on time, then we are good. Okay. What else? Now, always, guys, please keep an eye on your Canvas, your gradebook, any messages you get, anything, either it's an assignment or whether somebody has any remediation which is past due or due. Make sure everything you get the check mark, please. Okay, because that'll be forwarded to registrar soon, that whatever is done or whatever is not done, and that can impact on certain things. So make sure, please, that anything pending that is completed. And practice a lot of questions, guys, a lot of questions. Don't just rely on the question at the end of each chapter on the book, because there are only few questions there, and by repeating them, it doesn't make sense. You're not gonna understand anything. You're gonna technically just memorize them, and after that, it does not do anything productive for you. Do more questions on ATI. Do more questions on Evolve. Once again, not the one which are on the book. Additional ones, your ATI and Evolve, adaptive, and quizzing. That those are real important, because again, it's about preparing yourself for the exam. And when you attempt the questions, the question will require you to recall some information which you learned previously, and you recall it again and again. That will stick in your mind. And after you recall the information, you need to apply it into the question, and you may end up doing majority of the questions incorrect. Doesn't matter if you do incorrect. Make sure you read the rationale so that you are clear after that. Was there a question? Amy, you have a question?
No, it was an accident.
It was an accident? All
Yeah,
right.
sorry.
Taryn, you have a question?
Yeah, I was just asking if you'll still be proctoring the small group that had their drug test yesterday after this class for our ATI test.
Yes, ma'am.
Thank
For
you.
sure. How can I know? How can I say no? For sure, 100%. No, Carly, we cannot do that. Okay. Not early. Okay. Any other question, concern, guys? Anything else?
Will you be looking at our presentations that we turned in and offering any feedback that we need to change before we present, or we're just going to present as is?
Yeah, not anymore. It's I think too late to do so, because if we do that, it will take points off from your presentation. The canvas will automatically